All right, I'm going to go ahead and get started. This is again Jim O'Keefe, and I'm introducing the third of these midday webinars that we've called Lessons from the Front Line. This one is titled Outpatient Realignment Leadership Perspective. And I apologize for the name. I will give on the next slide a little bit of context, which is that I originally intended to come up with clinical webinars that just demonstrated what we were learning by taking care of patients with COVID-19. But as I got emails and messages from friends at other institutions, I realized that we had an opportunity also to share from the individuals who were designing the structures that were taking care of these patients. And so that's when I reached out to plan this webinar. So that's a bit about the purpose. In terms of what I'm doing with these, just for folks' awareness, is they should be in a playlist on the Department of Medicine YouTube site. They kind of go up every week, and it's just that we can share in some of the knowledge generated as we respond to COVID in the outpatient setting. So here we're doing webinar number 3, Health System and Leadership. And then I would highlight that next week we've had Misty Landor volunteer to work with me to present on post-discharge care. And that one is, again, meant to be clinical. So we'll have a hospitalist, a primary care receiving physician, and the transitional care team all speaking. And I believe another institution, UCLA, has a similar program, and they have a couple of the physicians who are going to give us a brief overview about what they've learned in the care of these patients too. So that'll be next week. We also have some morning reports where specialists, so this Monday, Dr. Kroll from psychiatry did a 5-minute talk on anxiety. Next Monday, Dr. Levy from ENT, and the following week, Dr. Chile. So I apologize for the time. Childcare is always juggling, and so finding little holes in the schedule, but we can move that to another time if people want. And again, those will be posted so that you can review them later. With that, I'll introduce our speakers. I would say it's very challenging to introduce one's bosses and do it well, so I'll let their institutional roles speak for themselves, and I know many people know these individuals, but our first speaker is Stephanie Vicent, who's the Director of Access Emory, Emory International, and Employer Health Solutions. David Roberts, who is the Director of our internal medicine practice, as well as his roles for corporate health, Access Emory, and Emory International. And Tina Ann Thompson, many people know, has been now our Emory lead for primary care, working closely with Ted Johnson. And with that, I'll turn it over.
Thanks so much, Dr. Keefe, and good afternoon, everyone. Definitely look forward to speaking with you a little bit about our journey in setting up both of our outpatient COVID positive clinics and some lessons learned as we are still embarking on that journey and hopefully getting to sustainability soon. Next slide. This will just give a brief lay of the land on what I intend to share with y'all today, starting with sort of where we began as developing a program that could extend the COVID response for our system, then providing a little bit of background on the 2 COVID clinics that we set up, both the virtual outpatient management clinic as well as the acute respiratory clinic. Then I'll share a little bit about our practice design and some of the key points that really drove our decisions as well as our outcomes with the practices, a few pressure points that we experienced along the way, and then some lessons learned. I also included a couple of additional slides in the appendix as well that you can view for your reference at a later time. Next slide. And so I have to give a very extended kudos to Dr. Dave Roberts, who really had an idea on a Sunday afternoon that then birthed both of our clinics. But really the focus was around the excitement and angst for our system response and just visions of what happened in other parts of the country as they approached and experienced their COVID peak experiences. And while the focus was on ensuring that we didn't have overwhelmed EDs rather than an overwhelmed system, the thought was, what do we do next with those COVID positive patients? Once they're tested, where do they go? Where's their home? Where will they have resources made available to them so that they don't go back to the ED? And so that really was what we were charged with doing, managing the care and evaluation of COVID positive patients, ensuring that we could divert unnecessary volume to the ED, and then given the shortages around PPE, ensuring that we could have judicious use of PPE that, again, would allow us to consolidate PPE concurrently with having the sufficient amount available for folks who needed to use it to care for these positive and presumed positive patients. And so again, that's what birthed both VOMC and then for on-site care, the ARC clinic. Next slide. Great. And so for a little bit of background on VOMC, it was stood up around the end of March. And again, the goal was to have virtual care be made available to the patients who were resulted from our central team of APPs who were tested throughout the Emory system in multiple facilities, including our screening clinics. It was a multidisciplinary approach with RNs, APPs, and MDs from across the system, as well as a very deep bench of administrative team members. We wanted to include a map just to give you an idea of the breadth of where we were serving patients and where they came from. And these numbers are a little bit dated and really just reflect our first 5 weeks of launch, but we have served over 500 unique patients, resulting in over 4,000 visits. Next slide. And teamwork makes the dream work. We certainly wouldn't be able to take what was an idea to being in production so quickly and so successfully without the help of some of you on the phone who are providers in this effort, but also the leads who helped drive these programs successfully. Next slide. And a little bit of background on ARC. Again, the goal of ARC really was to provide that on-site sort of more acute care that wasn't quite at the level of the ED, but certainly couldn't be managed virtually. So those really helped to drive our guiding principles. Again, this was one of those programs that really went from concept to production in literally less than a week, thanks to a lot of institutional and executive leadership support. Comparable to the VMOC, a multidisciplinary approach was used here too, from LPNs, RNs, MDs, APPs, and administrative teams with folks from across the enterprise to help get this off the ground. Similarly, in just a little under a month, we were able to see over 200 patients, resulting in over 200 visits. Next slide. Just wanted to give a shout out and recognition to the leaders who helped stand up and help operationalize the ARC as well here. And in terms of practice design, there were a couple of elements that were absolutely essential rather in getting us off the ground and to help ensure that we were successful during our operationalizing of these clinics. The first one was really around leveraging technology efficiently. It was a bit of a lift to digitize a lot of what we do in standard clinic processes to make it work within VOMC. But we certainly learned quickly, made a couple mistakes along the way, but were able to really leverage technology in a useful way to care for patients. Also, identifying and enrolling providers was something that was critical to our success. As we continued to go through our program and roll it out, beyond just our CV and Rockbridge providers, we understood that we needed to document the requirements, ensure credentialing and billing was solidified. And so that was one of our critical keys to success as we started to really scale the program. Again, we had to accelerate de novo clinic operations that usually take place over a course of months to a course of days. And it was simple things like, what will we call ourselves? What will be our main phone number? And then identifying schedules and durations of times for appointments. And none of what I mentioned would have been possible without assembling a strong business and clinical leadership team, really creating that integrated core team, identifying where we had the greatest area of need, and then just placing people in their areas of strength and getting out of their way really helped to ensure that we were able to launch successfully. Next slide. A couple of key levers of our program success really has been in system alignment. There are so many folks doing so much good work, and we really wanted to ensure that we could be complementary to those efforts, and when possible, really help to consolidate them to really have a greater impact, both for our clinics as well as what we were trying to do in the total COVID system response. Additionally, tapping into the commitment of every single person within this institution during the crisis was key. It was amazing to see things that typically take months be done in days, and things that usually take days be done in hours. And that was really leveraging everyone's desire to help and be helpful, and then deferring to their expertise to get things done. I can't overemphasize the importance of communication. You certainly can't over communicate during a crisis, whether that's horizontal communication within your teams, as well as up through leadership and down to the front lines. Then lastly, we really understood the importance of using data to drive our decisions. Looking at how many patients were going to be resulted as positive helped to determine what kind of scheduling we needed for VMOC and drive our capacity needs. Concurrently, looking at how many folks were getting COVID diagnoses from the ED and the inpatient setting helped us understand what kind of volume could we anticipate for ARC. Next slide. A couple of our pressure points, the biggest one really being that we had the benefit of having so many folks who had been redeployed to our clinics to help serve. But again, they were from multiple areas within the institution, and most of them working from home. And so ensuring that we could keep them engaged and optimize their performance was critical. Additionally, centralizing system resources and system efforts to ensure that we were having the greatest impact on our patients and for our clinics was key. And then developing resources and tools to make the process be seamless, whether it's Zoom letters to ensure that we can sort of plug and play as we add providers on, as well as the clinical guidelines that were ever evolving, and how we were managing our COVID patients was absolutely important. And then clarifying the scope of practice as it changed as the disease itself did. Next slide. And then just in closing, a few lessons learned. I cannot advise anyone who would be doing something like this themselves to do this. Documenting things early on is so very important. We're sort of running to be responsive and get these programs up, that we wanted to take a step back and pause to ensure that we're actually documenting everything we did, not only because it'll be helpful for folks in the future and for research and publishing, but even for day-to-day operations, just sort of having a blueprint to understand what our initial goals were, how did we get here, and then how can we optimize and iterate from there. So developing those protocols and documenting and recording what we did throughout from the start was really important. Again, you really benefit from having a great team in times of crises. Definitely couldn't be overemphasized in this case. We were able to really conjoin some really great folks and then empower them to do what they do best. And having leadership engaged and involved and on the ground is critical, just to really provide solace to folks given the uncertainty and stress of the time. I also would advise investing in a sustainability plan early on. Again, we were in response mode for most of the time we were getting these clinics stood up, but now as we are in sort of post-COVID peak world, having to build those sustainability models can certainly be challenging. So if there's a moment to pause and breathe and think about how we would actually continue these programs after we've set them up in the first couple of weeks of operations, it definitely will make the sustainability modeling a lot easier. Again, communicate broadly and repeatedly. And lastly, allow yourself a little bit of grace. When it's new, you're going to learn as you do. We were probably a couple of weeks into VOMC before we realized we didn't have a discharge process for patients. And so we of course, rallied very quickly to get that done, but wanted to ensure that the teams didn't feel badly about not thinking about that, because that's to be expected when something's new. And so just giving yourself grace to make those mistakes, recover quickly, and keep it moving. And with that, I just wanted to share our beautiful circuit board that really represents how you put the system first in building these sort of programs and plugging yourself in to ensure that your individual response will have system impact. And so as you see, if you haven't already on this slide, we wanted to tie in all the potential referral sources that could come into our clinics, the areas in which they could sort of be triaged and managed, and then provide a seamless way to access both VOMC or ARC or their PCP if that's appropriate. Again, that was a labor of love and was definitely a team effort, but I think resulted in some good outcomes in how we've been able to manage both clinics. So with that, we'll pass it on to Dr. Dave Roberts. Thanks so much.
Well done, Stephanie. Thank you. And thank you, Jim, for running the slides. A lot of what we did, Stephanie and I, of course, were at every step of the way in lockstep. So a lot of the things we'll say the same thing from a different perspective. And actually, why don't you just go ahead and go on to the next slide, Jim, if you would. To reiterate that this all happened in a time of fear and uncertainty. And I think probably the hardest part of all of this was trying to go somewhere when you didn't know what the ground was going to look like. And everybody's in that situation and we get it. But I think that's the hardest part is we're all really good planners and we know what steps to go, or what steps to take, but we just, if you don't know where you're going, then it's much harder. We certainly had the fear of the surge and overwhelming resources. We had the fear of exposing the staff and the patients. And so we were just ultra careful about how we were going to do things. We had the fear of the virus itself. Our PCPs, our staff, everybody was afraid of this because it was new and unknown. And then the most important thing was this abrupt shutdown of outpatient services. We live in an outpatient world. And what we ended up doing was trying to recreate an outpatient world that in a very different scenario. And so that was the main goal that we had. Go ahead, next slide, please. So we went from this kind of situation as normal, next slide, to basically ghost town. Our clinics were shut down, our phones were shut down, everybody was working from home. And I know everybody experienced all this, but this is the landscape and this is when you're trying to project. And that was what made things so difficult. Go ahead, next slide. So the system response is critical, and Stephanie focused on sort of the team response, but alluded to how well the system had responded. And I think it's really important to note that Emory, the system, had done a lot of pre-planning and early preparations. So a lot of the key elements had been put in place, at least for the inpatient focus, early on. We'd been through Ebola. We had our severe disease unit. We had our catastrophe plans and everything set into place. So a lot of that was dusting off what they had done before and making it available to COVID. There's a clear line of authority at Emory, which is very helpful, where we have decisiveness and open-mindedness from leadership down. The communication, as Stephanie alluded to, excellent, frequent, consistent communication was critical. Unfortunately, Emory has started setting up a lot of the daily huddles and leadership responses for part of their lean processes. What I would say is, Stephanie did say that there's no such thing as too much communication. She knows how grumpy I got. It sometimes seems like we were on a call every hour and we just couldn't get the work done. So there was a lot of communication, but things were changing every minute. So that wasn't inappropriate, but boy, it was hard to balance sometimes getting an update when you just responded to the previous update and things had changed in between. But thank goodness we knew about it when we did. The clear focus on the goals, and this is really important. Leadership never wavered from their commitment, and I'm talking top-down leadership, but mostly the folks in the practice group here that supported the abilities to move forward. They always were focused on patients first, patient and staff safety second, and stewardship of resources, both the PPE and the financial. But they always had their heart in the right place, and everybody was thinking the same thing, doing the same thing, and had the same heart. And that was really important, even to the point of all of the hospital systems in Atlanta were working closely together, sharing information and planning together, which is unprecedented when you take a bunch of competitors and sit them down in the room.
And then the other thing that's really important was the tremendous telemedicine readiness that was in place. And those things made everything really essential. Otherwise, you wouldn't have been able to respond as efficiently. Next slide, please. The system structure lent itself to that as well. I talked about the centralized. I talked about the inpatient care being very coordinated. And then the outpatient care, Dr. Ted Johnson and his team with his medical directors, Tina Ann, Fred, and Chris, having fabulous, and Lachey and the nursing with Carla, everybody had a fabulous structure in place that we could tap into quickly. So you didn't have to create the structure. All you had to do is tap into it and organize it. So Ted did a spectacular job with his authority, his leadership, communication. And again, we had a lot of folks working on the telemedicine, David Propp, several others that had been instrumental in getting things ready, and also Greg Esper from a system level. But what this all pointed out, that last line, is that large gaps were created by the shutdown in primary care. And that's what I wanted to focus on just a little bit. Next slide. Um, as a way of background for the ability to respond, a lot of this is just good luck. And some of the things that we were able to bring to the effort were pure luck. And we were a team of integrated academic internal medicine practice, meaning we have 11 providers, we have executive health, we have the international office and special constituent team. And so we had a bunch of really talented people that were used to working very closely together available in order to solve this. We also had a lot of geography. We had 21 exam rooms, 2 separate entrances, adjacent parking right outside the door. So there were a lot of favorable things that allowed us to be in a unique position to work. Dr. Johnson very astutely set us up to partner with Dr. Tina Ann Thompson, who will speak next, and who provided the system expertise. So we were small and isolated, and Dr. Thompson provided the system network and resources in place. And we're used to being an independent team that we just kind of solve our own problems because our problems are unique to the system. And so that worked out very well with Stephanie's leadership as well. And then just to comment on the determination and focus, it's easy when everybody's rallied against the enemy, and it was singular vision, and so nobody was fighting. Next line, or next slide. The phased response, just to summarize, and Stephanie went through this, I'll go through quickly. First was the telemedicine response, and next slide is the acute respiratory clinic, and you already have the summary of those. Next slide, please. Then we had to bring on the hospital planning and emergency room discharge. I'm going to go through that in a graphic way in just a second. So next slide. So just to kind of give you the lay of the land and the process, and this is aimed at other systems that have to try and figure out how to look at their system and analyze the weaknesses and where to go. And Dr. Johnson had thought a lot of this. Oops, back one. So the important part is at the bottom, we have our primary care system, and then we have the hospital and the emergency department as separate and distinct, somewhat coordinated entities. Next slide. Then the world of COVID came. Next slide. And then what the COVID did was brought about this big boundary, this big border of isolation and infection control precautions. And what's important is that primary care is excluded from that. We weren't able to participate in the care of the patients in our normal mechanisms. Big, robust system that was suddenly out of the picture, and really isolating us. Next slide. So the system put together a fabulous resource and extremely well run and very effective, our nurse run COVID hotline. And so suddenly we were getting information out. We were able to respond and answer questions and direct things, and have a side channel that brought everything, which was critical. Next slide. And then, of course, everybody was asking, do I have it? Do I have it? So the screening testing centers were set up very short order. That's a heavy lift and a big operation to run. And the screening system was necessary and I think very effective. However, it created a problem. Next slide. You had to have results. Everybody wanted to know what the results were. So they had to create a whole new system. And in this case, they used the APPs to notify the patients and to explain the results, which was helpful. But now you have a whole bunch of positive patients and we don't know what to do with them. Next slide. And that's why the virtual telemedicine was, how do we reach out people? How do we train a small number of people to take care of a lot of patients rather than trying to train all of the primary care providers? And so the virtual telemedicine clinic was a way of having, and Dr. O'Keefe did a spectacular job of guiding this group with their knowledge base. And so we were able to train a small number and eventually train more. Next slide. However, you started having patients that just needed to be seen in person. So very quickly, that's why the acute respiratory clinic came up. You couldn't just talk to patients. You couldn't send them all to the ER. We were trying to offload that. And next slide. So we had the tools that we needed. Once we had the virtual telemedicine and the acute respiratory clinic, we had testing, we had notifications. We still had some gaps, however. We've had patients being discharged from the hospital that we didn't know how to follow up. They're still in isolation period. So they're still in that gray shadowed area that we have to maintain, and that was the difficulty. And then Dr. Thompson set up a really elegant program for that, which we'll talk about next week. And next slide. And then the APPs, lastly, patients leaving the emergency room, we got them in there, they may or may not have been tested. So all of this had to be organized and structured and built piece by piece. Next slide. So this is, we're all going to show this because it actually looks a little complex, but I can't tell you how simplified this is. And Dr. Johnson started this whole process with a very intricate grid of trying to how you break things down, how you look at the resources, how you organize the whole system. And you had to build those pieces in order to have everything to stand on. And so Stephanie went through this, but this was really important that Dr. Johnson has started this system approach, and then it was just a matter of building the pieces. And so I think every system's going to have to do that. Next slide. So the lessons learned from us in summary is, number one, don't just design a house, but design a village. We kept building roads, and the roads all of a sudden would lead us nowhere. We would have a testing site, but you don't have any way to give results. You'd had results, but you had no way to take care of them. You could take care of them virtually, but then you had to take care of them in person. So it'd be easier just to kind of start, and if we had that grid to begin with, it would have been easier, but it just happened so quickly. Second thing is, make a decision, but then change your mind. What I mean by that is, you don't have time to really do the internal medicine approach to things where we run a lot of tests and test things and validate it. We had to make 100 decisions an hour. And so many of them were wrong, and so many mistakes were made. So we just had to make a decision and then adapt on the fly. So don't be afraid to make decisions, and don't be afraid to change your mind. The next is, really, you've got to utilize the talent. And Stephanie alluded to this. We've got such strong people, and we didn't even know how strong they were. Again, Jim O'Keefe has done great. All of Stephanie's administrative team, Ted's team, Tina Ann. So the number of people that have contributed that just had to be let loose, and you can't micromanage. So that was a real strength, but frankly, it's a little bit hard for us to do. The key lesson also is, solve a problem for somebody else, not for yourself. You can't be defensive. You can't be taking care of your own team, your own place, your own revenue at this point. And unfortunately, there was very little of that. And then the mistakes, I just didn't anticipate the end game. And Stephanie alluded to this. And basically, it's, how do you run a clinic when all the staff is leaving? We used redeployed resources, and we had no idea that 2 weeks after getting things up and running and people trained, that they start disappearing and going back to home units. So I think for others that might be considering setting something up, you should think through that succession plan that Stephanie alluded to. And that's it for me. Thank you, Jim.
Thank you, Jim, Stephanie, and Dave. This has been an absolute journey, and I could not have been placed on a better team. So thank you very much. Next slide, Jim. So I always start most of my presentations with my absolute true north, and that is, as my hat as a primary care physician, my hat as a leader of primary care, that our goal in primary care is to provide the continuity of care for our patients before, during, and after episodic treatment. Even during a global pandemic or not during a global pandemic, It is the rare patient that will not need at some point in their lives episodic care. Next slide. My agenda today is to talk about the primary care response, how we prioritized and deployed, the gaps that we noticed when we built our village, how we narrow the gaps, and then how we narrow the gaps and maybe close them even. Next slide. So primary care was tasked with assisting the system in providing care for our patients who both have COVID and, again, those patients who do not have COVID. And of course, primary care is well suited for this, right? What we do is take care of the patients through the continuum of their illness and through their lives. We educate, we screen, we test, we treat, we monitor, and we try to prevent disease where we can. So for us, this is just bread and butter to be able to provide care throughout the continuum of these patients. We want the ball to be given to us after hospital discharge, after ED discharge, after everything. We prefer it before that, and that's where the VOMC came into being. Next slide. So we still had to prioritize and the deployment of our physicians and advanced practice providers. We still had patients to be taken care of, even with the shutdown of our offices, and even with the increase in the potential surge that was coming, patients just had to be taken care of. We still had to do chronic disease management, still had to take care of patients before and after their hospital discharge, emergency room discharge. We still had to provide urgent care. I tell folks the abscesses don't drain themselves. We don't want them in the ER, and knees don't just magically get injected over telemedicine. So there are times that we need to provide in-person care. We had the screening clinic that was discussed, again, primary care, virtual management clinic that we just talked about with Stephanie and Dave, in the acute respiratory clinic, the low acuity emergency department, and then we all broke out our old textbooks to remind ourselves about hospital medicine should a surge come and we were needed there. The way we decided to prioritize where we would place folks is by utilizing self-surveys of our skills, and so that we would try to place folks in places that they felt that they would do the best care for our patients. And we used our data analysts to be able to place these physicians and APPs where they needed to be. Next slide. Again, I bring up our graphic here just to illustrate that even though that there are 9 buckets at the top, there will always be gaps. Next slide. And these were the gaps that we noticed when we were setting up the virtual management clinic. And I will say humbly that the gaps were pointed out by some of my colleagues in primary care. They were getting calls. They said, hey, Tina Ann, my patient got tested at a CVS Minute Clinic and they're positive. What do I do? My patient went to a neighboring hospital because I'm not geographically close to the main Emory hospitals. So again, our patient care gaps, there are patients who tested, there are patients who were presumed positive and never tested. Often these were household members. There are patients who tested positive for COVID. They were notified by our APPs, and they just declined follow-up in the virtual management clinic. We still are trying to figure out why somebody would turn down that service, but we were not 100% successful in converting every positive. There are patients who tested negative, and there are patients who graduated from the virtual clinic. They had met their 21 visits. They had been seen for 14 days virtually and been followed up, and they needed to land somewhere. And there were patients who one of my colleagues called COVID plus. They had COVID and a chronic disease. They had diabetes, sarcoidosis, heart failure, because COVID just doesn't just hit by itself. Next slide. So how did we narrow the gaps? Our colleague, Jim, did an amazing job of creating clinical guidelines. And these clinical guidelines helped us to direct our treatment appropriately. It also helped us to follow the patients for the 14 to 21 days that they needed to be followed. This was, however, extraordinarily labor intensive and something that really could happen only in the virtual clinic. But we were able to share what we were doing in the virtual clinic with our colleagues through digital communication platforms. We used email, we used Boxed, we used Yammer, we talked about it at Morning Report. I believe that we were able to tell all of our colleagues, most of our colleagues, what it is that we were doing. We did not keep what we were doing a secret, and that is a huge testament to this team. We shared our isolation protocols and our isolation forms. We shared the forms that we were giving to the caregivers. We shared our return to work forms and our recommendations. We shared our dot phrases, our smart phrases. And this was we were able to then help our primary care colleagues who needed to meet the needs of the patients we talked about on the previous slides, the patients who did not make it into the virtual management clinic, the ones who tested at our neighboring hospitals. We also had subject matter experts. We had our colleagues reaching out to the physicians and APPs who were providing this care and saying, hey, I've got a patient, she's been coughing for about 2 or 3 days and she just won't stop. What is it that you recommend? How do we take care of the asthmatic patient? What do we do with her inhaler regimen? Those kinds of questions, once you became a subject matter expert, once you've been doing this for about a week, those questions would come to us and we would answer those. The documentation that we created in the virtual clinic was very helpful and prescriptive to determine how sick the patient was and how much follow-up we thought that the patient would need. But we are one system, but with a couple of different EMRs, a few different EMRs, in fact. And so what we did was we used our documentation from the virtual clinic and we replicated it across our other electronic systems so that those physicians and APPs could provide care in a similar manner and understand the similar manner in the way that we were providing it here at the virtual management clinic. Next slide. But again, those gaps still remain. And the reason they remain is because we're not staffed in most primary care offices the way that we're staffed in the virtual management clinic. The way that we were able to provide intense twice-a-day follow-up, once-a-day follow-up, we're just not staffed that way. We're closed on the weekends. Sometimes we're closed on Friday afternoons. So the way that we perceive closing the gap even further is to create a registry so that with the registry, we could manage patients as a panel. And we could also leverage technology to be able to do symptom management so that if the patient received a survey on their smartphone and the patient was febrile yesterday, not febrile today, or short of breath yesterday and not today, we would be able to tell without having to make a phone call to every single patient. Did we mention there were over 500? There were 500 patients almost and several thousand phone calls made. We may not be able to sustain that, especially during a surge. So we're going to need to leverage some outreach technology. We have a great team working on that. And we have what we call virtual management franchising. It's not going to exactly be franchising, but I didn't quite know the word for it because I don't believe that we're going to be able to provide the staffing to the level that we're doing it in the virtual management clinic. But if possible, we need to come as close as possible. So I think that is my last slide, and I thank you all for the opportunity to share with you today our experiences here at the virtual management clinic. Back to you, Jim.
Thanks everybody who stayed on for, we went a little bit over time, and I really appreciate that. If our speakers are able, they may stay on for a couple more minutes. Anybody who has a question can either post to the chat and or unmute and bring up a question, but after that we'll wrap up. I'll just, one thing to say is that I see myself as a frontline clinician, and so the reason I wanted to do this particular talk today was just observing the setup of these clinics happening by administrators and leaders in real time was one of the most impressive, awe-inspiring things I've seen. And so I just thought it would be a neat opportunity to hear a little bit from the folks who did it. And so that was my perspective. And then the second thing would be interacting with colleagues on Yammer has really been cool, just to see everybody contributing, chiming in. And so again, just seeing myself as a clinician and contributor, it's probably one of the best community experiences I've had as a primary care doctor at Emory, really bringing people together in that way. So that's just some perspective. And with that, we'll finish. And any questions, I'll certainly stay on, and so can our speakers. I see one from Dr. Shah about a calendar invite for the morning report. Yes, I will at least post that to Yammer, and if there's enough interest, we can send it to everybody. I've tried to avoid cluttering calendars, but at least I'll post it to Yammer.
Thank you, Jim. Extremely well done.
All right, with that, I think we'll wrap up. Thanks, everyone.